Hello and welcome to Physician Perspectives. This is Dr. Jeetan Bendor. I'd like to speak about a micronutrient that has not been given the importance it deserves, and that is magnesium. The content of the presentation is sourced from scientific articles that have been published and are available online. I will present an image of the first page of the article on the right hand side wherever possible, as well as the reference to that article with the content here at the bottom. So magnesium is the fourth most common mineral in the human body after calcium, sodium and potassium. So magnesium is also the second most common intracellular cation after potassium. Important. Within the frame of a 70 kg individual, there is an average of 25 grams of magnesium in reserve, with 53% in bone, 27% in muscle, 19% in soft tissue, and less than 1% in serum. This is very important to note that less than 1% of magnesium in an individual is available in serum. Now, intracellular magnesium stores are found in high concentrations in the mitochondria, where magnesium plays a pivotal role in the synthesis of ATP, adenosine triphosphate, the energy currency of the body, from ADP and inorganic phosphate. In addition, magnesium is bound to ATP in order to yield bioactive form of ATP, that's magnesium ATP. And it is estimated that 3,500 human proteins potentially bind to magnesium. Here is a conservative list of the physiological functions of magnesium. Magnesium is involved in over 300 enzyme systems necessary for protein synthesis, muscle contraction, nerve function, blood glucose control, hormone receptor binding, blood pressure regulation, cardiac excitability, transmembrane ion flux, gating of calcium channels, as well as involved in energy production that is crucial for ATP metabolism. As I mentioned earlier, ATP is the energy currency of the body, as well as in nucleic acid synthesis. In this review paper titled Subclinical Magnesium Deficiency, a Principal Driver of Cardiovascular Disease and a Public Health Crisis, the authors go on to say that in developed countries, older data estimated that the prevalence of marginal magnesium deficit is 15 to 20% of the population. And this corroborates more recent data indicating that around 10 to 30% of a given population has subclinical magnesium deficiency based on serum magnesium of less than 0.8 millimoles per liter. The authors also reviewed about 37 articles and discovered that magnesium deficiency was a possible public health concern for older adults. As well, they mentioned that magnesium deficiency has been found in 84% of postmenopausal women with osteoporosis. That is a big number. This is interesting. The homeostatic mechanisms to regulate magnesium balance were developed millions of years ago. So if you look at the micronutrient supply in Paleolithic nutrition of former hunter-gatherer societies, it showed a magnesium uptake of about 600 milligrams of magnesium a day, much higher than today. So our homeostatic mechanisms and genomes are still the same as with the ancestors in the Stone Age. This means our metabolism is best adapted to a high magnesium intake. Now this is very important because serum magnesium does not reflect intracellular magnesium, the latter making up more than 99% of the total body magnesium. So most cases of magnesium deficiency are undiagnosed. So the abnormalities of serum magnesium may be the most underdiagnosed serum electrolyte abnormality in clinical practice today. The incidence appears to range from 12.5 to 20% on routine determination. So, how much magnesium does one need? That is reflected here on this table, and it depends on how old one is. So at birth we need about 30 milligrams of magnesium per day, and that goes on to about 420 in males when they're 51 or 320 in females when they're 51. It also depends on other physiological states like pregnancy and lactation. So here are some common food sources that contain magnesium that have to be consumed every day in order to keep good levels of magnesium going. Here is a list of magnesium salts that are available as supplements. Please note that this list gives us a list of magnesium salts such as magnesium oxide, hydroxide, chloride, citrate, orotate, salicylate, mandylate, glycinate, or taurinate. It also mentions how good these salts are available or bioavailable to the body and what they can be used for. There is also another one or two that are missing from here, and one that I can remember right now is magnesium L-threonate. So it is important to make sure that your patients or people get the right type of magnesium and maybe a combination of magnesium to make sure that the absorption is best. I should mention here that magnesium salts can cause a challenge with some patients, as in loose stools. So it is important to identify the type of magnesium that you're giving your patient or you're consuming so that you can take another salt in order to make up for the challenge that one salt has, or have a combination of various salts of magnesium. The causes of magnesium deficiency is quite complex. It goes unnoticed in most cases. So the 3 slides here basically are a list of the causes of magnesium deficiency. Let me just point out a few. For example, acetaminophen or paracetamol toxicity, alcohol or alcoholism. Aging causes a challenge with absorption of magnesium, bariatric surgery like small intestinal bypass surgery, intake of caffeine, excessive ingestion of poorly absorbable magnesium, enzymatic dysfunctions, estrogen therapy, hyperparathyroidism and hypoparathyroidism, hyperthyroidism, as well as medical challenges like heart failure, hemodialysis, laxatives, and so on. Here are some of the clinical signs of hypomagnesemia or deficiency. The 2 columns, the one on the left are the severe signs and the one on the right are the less severe signs. So severe signs could be arrhythmias, convulsions, coronary heart disease, depression, hypertension, heart failure, migraines, osteoporosis, seizures, sudden cardiac death and tachycardia. And some of the less severe signs could be aggression, anxiety, confusion, cramps, hyperreflexia, muscle or muscular weakness, spasticity, tremors, and vertigo. So these take-home messages from this paper, Chronic Magnesium Deficiency and Human Disease, Time for Reappraisal, makes sense, where they say chronic magnesium deficiency is common, particularly in the adults or elderly, associated with major pathologies and common drugs, often associated with normal serum magnesium concentration, and is inexpensive to diagnose and easy to treat. Let's look at some clinical papers on magnesium. This is published in 2016. The authors looked into dietary magnesium and its positive association with skeletal muscle power, muscle mass, and also looked into inflammatory marker called C-reactive protein. So this is a cross-sectional study of 2,570 women aged between 18 to 79, and they looked into magnesium intake using a food frequency questionnaire. They looked at muscle and fat mass using DEXA. They looked at leg explosive power and grip strength. They of course looked into HSCRP, and what they found was that a higher dietary magnesium intake was significantly associated in a beneficial direction with indices of skeletal muscle mass and leg explosive power, and also with circulating CRP concentrations. They also further state that although their findings applied to women of all ages, it has most or the better or greater benefit in women aged 50 years and above. This article was published in 2021 in the Journal of Headache and Pain, and it is a study on magnesium with sodium valproate on its own or in combination. This is a randomized, single-centered, double-blind, parallel group controlled clinical trial that is conducted on migraine patients within the age range of 18 to 65. So they had group A, who had 200 milligrams of sodium valproate and a placebo tablet for 12 weeks. B had 200 milligrams of sodium valproate twice a day and 250 milligrams of magnesium oxide twice a day, and the group C had 250 milligrams of magnesium oxide and a placebo for 12 weeks. And they report that the obtained result of the study revealed that magnesium could enhance the anti-migraine properties of sodium valproate in combination therapy and reduce the required valproate dose of migraine prophylaxis without the side effects, of course. And here are the results of group B. In this update on magnesium and bone health published in 2021, the authors reviewed 28 eligible studies, 9 studies concerning magnesium blood studies, 12 concerning magnesium intake, and 7 studies concerning magnesium supplementation, alone or in combination with other nutrients. And they say that considering the intervention studies published to date on supplementation with magnesium, most have used this mineral in the form of citrate, carbonate, or oxide, with the dosage varying between 250 and 1800 milligrams, that's per day. And in all studies, there was a benefit both in terms of bone mineral density and fracture risk. This interesting publication in the year 2019, titled Impact of Magnesium Supplementation in Muscle Damage of Professional Cyclists Competing in a Stage Race. So they looked at a 21-day cycling stage race, and in one group of 18 male professional cyclists, they divided them into 2, 9 each, and one group was supplemented with 400 milligrams of magnesium for 3 weeks, while the other was on a placebo for the same duration of time. Blood samples were collected immediately before the race, mid-competition, and before the last stage. The authors report that Pmax, IE max, and VO2 max were slightly higher in the magnesium group compared to the control group at the end of the study. They also report that magnesium levels decreased significantly through the race, that's mid-competition and before the last stage. However, the decrease was significantly more pronounced in the control group when compared to the magnesium group. Okay. Now they also went on to look at muscle biomarkers, and they report improvements in muscle integrity in the magnesium group were modest when compared to the control group. Now they conclude that magnesium supplementation seems to exert a protective effect on muscle damage. This paper was published in the International Journal of Cardiology, titled Magnesium Orotate in Severe Congestive Heart Failure. So the aim of the study was to evaluate adjuvant magnesium orotate on mortality and clinical symptoms in patients with severe heart failure under optimal cardiovascular medication. So it was a monocentric controlled double-blind study with 79 patients in severe congestive heart failure, that is NYHA score of 4, under optimal medical cardiovascular treatment. And they were randomized to treat either magnesium orotate or placebo. Magnesium orotate was 6,000 milligrams for 1 month and 3,000 milligrams for 11 months, so total of 12 months. Now, after mean treatment for a year, the survival rate was 75.7% in the magnesium orotate group compared to 51.6% in the placebo group. Clinical symptoms improved in 38.5% of patients under magnesium orotate, whereas they deteriorated in 56.3% of patients under placebo. So what the authors go on to say is this significant higher survival rate and the improvement of clinical conditions in the magnesium orotate group present good arguments to use magnesium orotate as an adjuvant therapy in patients with severe heart failure. So patients in NYHA stage 4 are more or less completely dependent on the caretaking of relatives or nurses. A change to NYHA stage 3 was shown for some patients at least in this study under magnesium orotate, a certain degree of independence, and which also improves quality of life. Finally, they say that the excellent tolerability of magnesium orotate should facilitate the decision of this adjuvant therapy as an option. This is an interesting article where authors looked into the effect of magnesium supplementation on blood pressure in individuals with insulin resistance, pre-diabetes, or non-communicable chronic diseases. It is a meta-analysis of randomized controlled trials. So basically the authors were looking into the determination of the pooled effect of magnesium supplementation on blood pressure in participants with preclinical or non-communicable diseases. So they identified randomized controlled trials that were published in English before 2017, May of 2017. So they identified 11 RCTs and included 543 participants with a follow-up period that ranged from 1 to 6 months. The dose of elemental magnesium that were used in these trials ranged from 365 to 450 milligrams of magnesium per day. So all studies reported blood pressure at baseline and the end of the trial and at the end of the trial. The weighted overall effects indicated that the magnesium supplementation group had a significantly greater reduction of both systolic blood pressure and diastolic blood pressure than did the control group. They also went on to say that the pooled results suggested that magnesium supplementation significantly lowers blood pressure in individuals with insulin resistance, pre-diabetes, or other communicable chronic diseases. Here is an interesting double-blind placebo-controlled clinical trial where the authors looked into the efficacy of magnesium supplementation to improve insomnia in the elderly. So they had 46 elderly subjects randomly allocated into the magnesium or a placebo group, receiving 500 milligrams of magnesium or a placebo for 8 weeks. Questionnaires on insomnia severity index and sleep logs were maintained. The authors conclude that supplementation with magnesium appears to improve subjective measures of insomnia such as ISI score, sleep efficiency, sleep time, and sleep onset latency, early morning awakenings, and likewise insomnia objective measures such as concentration of serum renin, melatonin, and serum cortisol in the elderly. Here is my disclaimer. This is Dr. Jeetan Bendor. Thank you for watching.